Welcome back to When IT Hits the Fan, brought to you by Rhyno Healthcare Solutions. Today, I'm with Dr. Kathleen Mazza. Kathleen, thank you for joining us.
Thank you for inviting me.
We always start off the same way. Who are you and what do you do?
Sure. I am a nurse by background. I've been one for a long time, and now I am working in the biomedical informatics for a large integrated healthcare delivery system um, with a focus on population health initiatives, how we can use technology to improve health outcomes for the larger groups of people.
And what was the path to reaching that career?
Very unintentional. It was, I I was the director of a home infusion program within a larger home care agency. And I happened to be walking past the conference room as the chief operating officer stepped out and said, and she looked at me and said, "Oh, you probably should come in for this meeting." It wasn't something that was really planned, but it was fortuitous. I had gone in, and it was about uh, taking the nurses onto laptops, and rather than the paper notes they were completing at the time. And because I was the director of the high tech home infusion program, I was perceived to be as somehow the most computer savvy nurse in the room. Um, and in all honesty, I came home that night with a new laptop. It was the old ones with the tablet, like you could spin that back and make it flat so it could be a tablet or a laptop. And I put it on the kitchen island, and my son came by. He was 12, and in all natural curiosity said, "What? What's that?" Like it was a new device in the house. What's that? And he was a Mac user already. He was pretty techy. And he said to me, so I said, "Oh, the nurses are going to go onto laptops, and I've been asked to be on the committee." And he looked at me kind of like incredulous because this poor kid was my tech support team, at home. And he looked at me and he said, "You're the best they've got." And so I wound up doing eventually a PhD in biomedical informatics, and all, but that humbling moment was just so. And I tell the story because I think there's a lot of people in healthcare who think they don't have what it takes for IT, and I just want you to understand, if you're feeling that imposter syndrome, I have a PhD in biomedical informatics, and sometimes I'm like, I don't really know computers. It's okay. There's a space for you here.
And what a perfect story. And he couldn't have been a better age to have found that laptop at that
No,
time.
it did. Fast forward, he went into the military, and when he got his first promotion, I gave him the look, and I said, "You're the best they got."
No, that's perfect. And so, for the audience at home who may not know a ton about health informatics, can you tell us, can you walk us through it, help us understand how it helps people, how the data is gathered, soup to nuts?
So, if I go back to the beginning of my career, I've been a nurse since the 80s. Charts were all on paper. If the doctor wrote an order, it was on a carbonless triple copy kind of piece of paper that somebody took the pink foot one out and put it in a basket, and then somebody transcribed it, handwriting it onto a medication administration record and sent a copy to the pharmacy. And, we all had to interpret everything. It just was very, very manual. And the meaningful use certifications and different things at the turn of the century really drove electronic medical records adoption. And it offered a lot of promise for improving healthcare. And we haven't delivered on some of that, but I think we're getting closer now. So biomedical informatics says, like, we have a lot of data we've accumulated now in healthcare. What could we know about people, and how could we use that in population health informatics to drive better outcomes for an individual, to drive better outcomes in a zip code, to drive better outcomes for a disease category, to make it easier for patients, less friction to receive care, make it easier for providers. I think electronic medical records, if I really had to say that the downside there, we've made it hard for providers to interface with patients in meaningful ways. They're busy looking at the screen and they have to click, and then they have to go home and finish 4 hours of documentation. It's all a little broken there, but I think the things that are coming down the pipe now offer a lot of excitement about what we can know about people, how things like generative AI and machine learning can let the doctor know when they open the computer, this patient has these things going on. Don't forget to ask about this thing from the past, and then help them craft their note and things in real time, because we have tools that we have never had before.
And I think that's a perfect, almost like evolutionary path that I completely agree that for the last my experience with healthcare, all of it, there is this feeling sometimes that the doctor is facing away from you. That of course we want to leverage technology as much as we can at the current instant in time for what the technology can do in that moment. And so we do need the EMRs. We need them all to be integrated. We need them all to be interoperable. But I completely agree with you that we are at such a beautiful time where we're going to be able to have both. We can have the benefit of on paper where the doctor can look you in the eye and turn around and be away from the screen. And then also the benefits of having even new technology that's coming in that's going to be built upon what was already so useful. And so yeah, I think everybody at home knows from every episode how much I love these topics. But let's drill into it even further. How do you use data and technology to close care gaps? I think it'll also help with the financial crisis that as I get more and more CIOs on from both payers and providers, all I hear is that money is very, very, very tight. There's also provider burnout to worry about. What about data and tech can be solving all of these problems?
Sure. So we're trying to automate things as much as we can. We're asked consistently to do more without more resources added. Um, and maybe that's not fair because our health system is investing heavily in technology. So I don't want to make it sound like they give us two nickels, but not more people. It's hard to find people with the skills, and when you do find them, they're expensive. So if we're going to be given the technology, we can't also expect to be given more people. So care gaps, perfect example. Um, we have a really robust care navigation arm of nurse practitioners, physician assistants, or registered nurses, social workers who manage high risk populations. So recently discharged Medicare patients who belong to the CMS STARS quality ratings program. Patients with chronic illnesses, our own employee population. We're self-insured, so every dollar you spend on healthcare, you're trying to get ahead of things and make sure that that if someone is diabetic and they fall into that group, that they're getting eye exams, they're getting their blood work done as ordered, according to recommendations. For they're at a certain age, have they had a colonoscopy? We have a vested interest in early detection because it's the right thing to do, but also we have a financial interest. And if they get sick, they're our employee, and now we have an employee out, which creates another layer. So, we have all the interests aligned, which is kind of a unique, to me, a really unique model. I think a lot could be learned from that because in the US, we often have such competing, misaligned priorities. But here we have everybody's kind of rowing in the same direction. Like we have clinicians who want it, patients who want it, the payers want it because the payer is us, like it's all kind of aligned. Um, and so for things like gaps in care, we can now mine that data, whether we are the payer or there's external payer data coming in to say this patient is hitting the list saying they haven't had this done. But wait a minute, we see this other thing in the EMR. Does that meet this need? Can we cross them off the list? And if we get that nice clean list and say, okay, these are our patients who need a mammogram, a colonoscopy, an A1C whatever screening kind of or testing done, we're using things like automated email, automated chatbots. We've done a lot with here at this organization for, gosh, 8 or 9 years already. We've been working with chatbots to outreach to people to say, is this happening for you? Can we help you get this appointment? Can we help you manage this? And sometimes that's all the prompt somebody needs, is just the reminder. It happens to me too. I saw one physician and she said to me, gee, it's been a while since you saw Dr. So-and-so, what's up with that? And I was like, oh, there was a pandemic. I forgot. I saw a billboard in Pennsylvania this weekend that actually made me laugh out loud. It was a cartoon of a woman on the phone, and she was kind of shouting into the phone, it's been 5 years. And it was for a dental clinic. And I thought, it's brilliant, because somebody driving by that is going to go, oh my gosh, I think it has been 5 years. So we use technology to nudge people. We'll send you a text. We'll send you an email. You have to be careful with the PHI protection and some of those things, but there's lots of opportunity to use technology to meet people where they are. And what's exciting about what's coming down the pike with some of the machine learning and AI and things that, have offered promise, and they've been talked about a lot, but are kind of really, it's happening now, is knowing this patient will respond better to a phone call. This one, they'd rather get a text, and it probably should be after 2 p.m. Like, we're going to get there in the next few years. And it's really exciting to think how technology could remove some of the burden of having more people on the phone calling. Listen, if I get a phone call while I'm in a meeting, I'm like, leave me alone. Just send me a text. I'm coming to that dentist appointment. You don't have to call me up. Text me. I'll tell you yes. So I want them to know me that well.
And I want to even drill further into the chatbot initiative, where I I obviously work very much in this space, and on occasion I've heard people say things that it's sort of removing the human touch, or that people will bristle against it. But just even talking from my personal experience, I know that sometimes I would rather just text to that I'm coming to an appointment, or speak to a something I don't have to make eye contact with, if I can be that that honest. Have you found in your experience that sometimes the chatbot actually is more helpful for some people, for some populations?
Percent. I mean, for simple things like appointment reminders, I think most people who use a phone and who text would rather just get a text to say, yes, I'm coming, or I need to reschedule that. It's much less disruptive, and it can be an asynchronous kind of interaction, where if somebody calls in a moment that's not particularly convenient for me, and then I have to call them back and maybe leave a voicemail, and then they have to call me back, like, it just gets a little crazy. But I do think we're just finding some things that are kind of surprising us, and maybe shattering some of that bias we have to think that people find this as less warm touch. Um, and I have two anecdotes that I've shared before that I think really sum it up. We had one patient who was rather a high-powered New York exec type, who had been in one of our hospitals, and he had gone home, and he was getting the chatbot follow up. And basically, we use that for 30 days after the patient goes home. And it's the questions are you taking these medications? If you're not taking it, why? Is it a side effect, or the copayment, or just trying to figure out who needs to call this patient if they have an issue? You have your follow-up appointments. For this particular patient, he had a diagnosis of heart failure. So one of the things we were tracking was his weight. And we can do wireless scales and all kinds of things, but this one, it was simply him punching his weight. The question said, hey, have you weighed yourself today? Yes. What was it? And he punches in 190. I'm making whatever. And it was up a few pounds over the 3 days that he'd been home. And that triggered a nurse looking at a dashboard to call him. And ask him about his symptoms and things, because this was trending in a direction that would have him back in the emergency room, um, and within the next few days. And he was very confused by the phone call. And when she finally said, "Well, your weight has gone up. I saw it that you just said that it was 190." And he was like, "Whoa, whoa, whoa! Wait a minute! You're telling me you're calling me because I just put that number in my phone, and you know that?" And she said, "Yes." And he said, and you're a nurse, like surprised. And she said, "Yes." And he said, "I was in the hospital and hit the call bell and I couldn't get a nurse to come in this fast. And here I am at home and you're calling me and answering, responding." He was delighted with it once he understood the connection and how technology had him still being cared for outside of our hospital walls in a way that felt really personal for him. And so technology in that case was kind of transformational to his experience of monitoring his own health. And then the other story that surprised me was we are using chatbots to monitor pregnancy and offer a lot of educational materials. Really motivated age group with often have a smartphone, women of childbearing years. This is a really rich audience for this kind of technology. And the chats continue after the baby is born to monitor for things like postpartum depression, any cardiac symptoms, things that women are at risk of in the postpartum period. And a woman came into the doctor's office for her postpartum visit and saw the doctor and the nurses and showed pictures of the baby and all of that, and it was lots of excitement and cheers. Hey, that's great, congratulations. And then went home and answered the questions in the chatbot and revealed pretty significant postpartum depression with suicidal thoughts. And we followed up quickly and got her the help that she needed. And in talking about it later, she said, I was embarrassed to say anything at the doctor's office because it felt everybody was so excited about the baby. And I know it's a blessing. And I know, intellectually, I knew all these things. But with the chatbot, I felt the anonymity let me be more honest with this a chatbot agent than I could be face to face with these people who I've known for years now. And so for certain target audiences, these tools may actually be just the right level of care, not necessarily cold or impersonal. We have to, and this is where I think AI in the next few years can help us figure out who will benefit the most from this type of technology. And I think behavioral health is a really ripe field for some of this, for finding people in trouble and for helping them in real time.
And I also like to think about the educational aspect when it comes to health. The way that EMR, EHR interoperability works is that sometimes some hospitals, it's great. You can walk from, when you go into surgery, they have all of your information. When you go into outpatient, they have all of your information. But for others, there's a certain level of self-advocacy and medical understanding that a patient might need to have in order to continue to advocate and make sure that everybody at every touch point knows everything that's going on. Something that I've been surprised about is that in speaking with healthcare systems that are implementing AI, as well as speaking with clinicians and providers about what they might want from AI, what I hear a couple times is that they're hoping that it can bridge the gap and help them who have studied this in such an intense way, help them find ways to get the patient to understand it at their level and in their language, if there's a language gap as well. Have you found that to be the case in any way? Do you think we're headed that way?
I do. I think natural language processing is really going to drive a lot of this. I'm not saying it's going to change in the next year for a lot of patient-facing things. It feels a little risky, I think, to providers still. Understanding that how we might understand someone's level of health literacy so that the education we're sending them through a chatbot or at some, in a education document that we print out and hand them when they schedule a colonoscopy, making sure that it's at a level they can understand. And languages, I mean, the ability of language processing to translate documents now into almost any language. Even I just saw a podcast where they were talking about language to sign, and that it's, that's becoming a normal thing, that you can hold up your phone, listen to something, and it can mimic the sign language of what the person is saying. And I'm like, these are game changing technologies, really exciting to imagine. And to make it really feel personal to the patient, that they feel known. um, the promise is there. It's an exciting time in healthcare.
It is. It really, really is. And just for the sake of good, journalism and media, even though I'm so stars in my eyes about this topic, I have to ask, AI has so much potential in healthcare, but from your place of expertise, what are some of the limitations? What do we have to watch for in the next couple of years? What guardrails do we need to place in order to pick the fork between utopia and dystopia?
I think, of course, with all of this promise of AI, machine learning, and I'm like you, I'm excited about it, but I always am cautious to make sure, like, we can't build bias into these systems. We need to be really careful how we that our data that we're using to build a machine model is accurate, complete, timely, all of the thing. Like, what do we have what we need to build good machine learning models? And if we don't, to recognize that and say, this is going to be limited because we're duplicating patients in this record, because one says John Smith and one says J Smith and one says J Smith Jr., and we're counting him 3 times. And that may be skewing what we're trying to understand better. And so as we get better at collecting our data, at merging our data, at cleaning our data, and knowing that we're working with good stuff, then I think we'll do better on some of that. But the truth is, like, some of what's broken today is we could very easily build into these systems and make it be broken faster and bigger. And and that's not really. So when I talk with tech companies, they have lots of solutions that they want us to adopt, and it's exciting to think about, like, virtual reality and things, and in a patient room, like, and then the nurse in me is like, oh my gosh, like, what does that look like if I walk in the room? And like, and so I think we want to be really careful how we go. And I often recommend start with a really small project. And I mean, I could be talking 5 patients, and people, have big dreams. And I'm always like, we will learn more from the first 5 patients than we might learn from the first 500 patients. And so, there are limitations to what we're willing to put in front of patients. I think using things like AI to help figure out scheduling or educational materials for prepping for a procedure might feel safer than monitoring patients and letting them have free text in chat bots when we don't know if they're saying their chest pain is, my heart hurts because I'm sad, or my heart hurts because I'm having a heart attack. Like, we have to show clinicians, we have to build trust. And the way we can do some of that is to build models that are transparent and can be understood by a human. A simple example: we have a program that follows heart failure patients when they leave the hospital, the one I was mentioning before with the chatbots. Identifying heart failure patients while they're in the hospital is not always straightforward, because they come in with the shortness of breath, fatigue, They don't come in necessarily saying, I'm having heart failure. They come in with a symptom. And then we do a series of tests over the course of their admission. And by the time they are leaving 3 or 4 days later, the code of heart failure is on their record. And the, the reason for that hospitalization is coded to be heart failure, but the patient has left the building, like they're gone. So now we want to engage them to use this chatbot. We have a much better chance of doing that if we get them in the hospital and we say, when you get home, your phone is going to light up. That's us. And we want you to do this thing. And this is what it's going to look like, versus them being at home and getting a text and saying, who is this? I don't even know, I don't want to engage with this. Maybe this is spam. Is it a fraud thing? So the timeliness of identifying heart failure patients and engaging them with this chatbot in the hospital was really important to us. And the source of truth for that is the DRG for that hospital admission. The code that is assigned to that hospitalization tells us this was a heart failure admission. It's going to be billed as a heart failure admission. It's going to be quality rated, all of the things. And so we looked at that model and said, I work with a nurse who's very brilliant in data science. And we said, what else could we know? And sooner than the DRG, because that's a real end stage piece of data. And it was, well, are they on these medications? Did they have these tests done? What's their ejection fraction? What's different things that look for these words in this report, look for these words in notes, look for these words, and built a machine learning model that identifies patients day 1 or 2 of the admission. We're finding them because there's a pattern. We know it intuitively. So showing providers a model that they can understand and understand, know what the machine is looking for, helps build trust. Because then they say, oh, so now next time when we come back and say, we want to do this for pneumonia, or we want to do this for, whatever the diagnosis may be, there's a trust factor because they've seen it, it's been transparent, and they understand. If we can't explain it to them, they won't. It's very hard to get them to adopt it.
And this is one of those episodes that I wish it was a 3-hour podcast and not a half an hour one. But due to my obligation to step into the next portion of this podcast and not listen to you tell tech stories all day, because believe me, that's really what I want. This is the touchy-feely portion, we're entering the part where we talk more about career and not specific industry. But if you were to have a magic bottle where you could put a piece of advice in it and send it back to yourself at the beginning of your career, and it has the hard-won wisdom you know now, maybe a lesson or two you wish you had known earlier, what might be in the bottle?
It's I would say, don't be afraid, and don't be afraid maybe to say, I don't know that. Can you tell me more? Because just like our conversation is happening here, if you go to somebody, the first time I was in a tech meeting with the computer guys, and we were talking about bypass surgery, and the acronym for that is CABG, coronary artery bypass graft. And finally, we walked out of the room, and my head was swimming with acronyms: UI, UAT, GUI interface. I was scribbling notes, I have to go and Google all these things. And this guy tapped me on the shoulder as we were leaving, and he says, "Can you tell me what a cabbage is?" Because I don't. He's understanding, a head of cabbage at the grocery store. He's confused, and we had a good laugh, and I said, "Can you tell me what UAT is?" And there was a moment of understanding that everybody in this brings something to the table. So I made the statement earlier about imposter syndrome. I felt like I'm working in information technology, but I don't know anything about information. I didn't learn that in nursing school. But what I think I would tell an IT person, a healthcare provider, clinician person, a project manager, everyone comes with their expertise to this table, and no one knows it all. And that's okay. Don't be afraid to say, I don't know that part. Can you tell me about that? Because the clinicians know the problems we're trying to solve. Um, the providers know the pain they're feeling. Like the patients know what is inconvenient or expensive or whatever. The the IT guys know the technical solution. It's when we all get at the same table and say, well, this is what I'm feeling. Well, this is the problem we need to solve. These are the tech options. These are the ones that are most cost effective. It, uh, it all, everybody wins at that table. So just admitting I don't have all the answers, but understanding you still bring a lot to the table. Um, I think would be recognize what you do know.
And so I just want to thank you for sharing your time and expertise and just being so generous with your stories. I want to thank the people at home for listening to our episode. As always, we're going to have another episode coming out next week. And do remember that when IT hits the fan, call Rhino Healthcare Solutions.